Hey everyone, it's Adam Farkas. Welcome to another ODwire webinar. And now tonight, before we get started, I just want to remind everyone, as the presentation unfolds tonight, you can ask questions. I will take your questions and hold them aside, and at the very end, we'll have a Q&A with our guest tonight. So again, find that question box on the right side of the screen. You can type into it. Those will come straight to me. And then we'll have a little verbal Q&A at the very end. And the other question I know people are going to ask, obviously we had our little giveaway today for the Starbucks gift card, and we will be emailing those out to you guys tomorrow. So check your email box and always remember to check your spam folder, which is what I remind people to do, because occasionally Starbucks emails do end up in your spam folder, but it is not spam, it is real, it is caffeine, and it is for you. So anyway, thank you for being here tonight. And tonight we have a really cool and interesting show for you. I think most of the people who sign up for these events, like me, you're small business people, right? You run your own practice, and you know how difficult it can be to actually manage things and to get things started. And tonight's story is a really interesting one, talking all about telehealth and using it to extend your reach. And our guest tonight, Dr. Rasa, did something sort of extraordinary. You've heard her before, but I think that it bears repeating. In a span of 5 years, she went from opening her single location 5 years ago. She just opened her 16th location, and this is around the Chicagoland area. So in a highly competitive market, she went from nothing to 16 offices in 5 years. And tonight's all about how she was able to pull this off. And we're going to just sort of discuss sort of her secret formula and how she was able to do it. And technology plays a huge part, right? Because you can imagine, managing one location is hard, 2 is even more difficult, 16 is incredible. And we're going to hear from her today. Dr. Rasa actually is in Mexico, and so we're going to have her on for the Q&A portion. But we recorded her talk actually earlier because we wanted to make sure that she'd have good connectivity. And we couldn't guarantee it in Mexico. So I'm going to start up her talk right now, and at the very end, we're going to do some live Q&A with Dr. Rasa. She did make it here, and she does sound good. So I'm going to get it started, and I hope you enjoy it.
Thank you so much for having me here today, Adam. I really appreciate it. I'd like to share my knowledge of what I have built with my business in hopes that it can help others. So today I will be covering a few things on how to launch an on-demand optometric practice, how to redefine the role of the optometrist in today's need for patients, and also introducing how to be able to increase access to care in a very flexible way for the patient. Of course, we'll have a little bit of time for questions and answers afterwards, and I look forward to them. So a little bit about myself. I am an optometrist who graduated from Illinois College of Optometry in 2004. I have been practicing for nearly 2 decades, and for the most part of it has always been as an independent optometrist and also as a private practice owner. About 5 years ago, my partner and I, we started a company called Big City Optical, which is a full scope optometric practice with the retail component. Today, 5 years later, we span 16 locations across Chicagoland area. When I first started Big City Optical, it was quite humbling to go back to those days that I recall being a student. I needed to get as much business knowledge to succeed in this endeavor. So I surrounded myself with experts in many fields. I talked to equipment vendors, retail consultants, technology companies, clinical care experts to get as much as I can, like a sponge. So when you start a cold practice, or in general start a private practice, the biggest thing weighing on you is the return on investment. How do you invest in technology? What are the things that you're spending your money on to just get started? So for me, I think when I was approaching this question, thinking 5 years back now, the biggest problem I was trying to solve for was how to maximize patient exam availability. In the sense, how, where, and when the patient wanted to receive care from me. I wanted to become convenient and to offer options to patients in that on-demand type of service. So that was the idea of starting this practice. And as you know, there were certain circumstances of the pandemic getting in the way. And that idea of the business model actually helped for me to practice and expand during the pandemic. So today, 5 years later, we are spanning about 30-mile radius from north to south across the very congested, high-density Chicagoland neighborhoods, and we became nestled in those neighborhoods as the community eye care office. As you can see, the average rating on Google and Yelp is 4.8, which outvests the national optical retail chains that are my competition in the area, but is also on par with the private practice practitioners who are single doctor owner offices. From what this obviously is encouraging me is that the patients see value in the care that they receive at Big City Optical. And by providing that great care, great customer service, we gain more patients. Today, we are about 35,000 active charts in our EMR, counting up. So here I'd like to give you a glimpse on how I selected this technology to fit this model in my mind to succeed. So the technology selection to me, there were a few important things that I had to stick to. One, I had to make sure that it was easy to use. Onboarding new technicians, new employees, it had to take no downtime to teach them how to use this technology and to gather this data for me. Two, it had to really yield accurate, reliable, and repeatable results that I could trust. And three, probably the most important one for me is that this technology aggregates so much valuable info that I was able to focus more on educating and answering questions instead of gathering the data myself. What you see here on this slide is a typical pretest area in my office, and Chicagoland obviously is a quite expensive real estate, so my offices are relatively small, so footprint is of course important. Here the patient just swivels from one side to the other and is able to get a lot of data collected within about 6 minutes. Right here from what you can see. On the right, we have the Visionix Eye Refract and the lens analyzer. And on the left, we have the VX650 that gives us a lot of health gathered information that I can see uploaded on EMR within those 6 minutes of collecting the data all together before I even see the patient. So the important thing here also to note, and I'd like to pause and explain this, is that the optometry field is changing. And the optometrist role, in my opinion, needs to be slightly redefined. And that was one thing I took up as I'm building Big City Optical. The art of refraction has been previously oversimplified as the role of the optometrist. Now today, we are eye care physicians that play a critical role in patients' healthcare, more medical than refractive. These statistics are scary. It is estimated that the number of people in the United States who are blind or visually impaired by 2030 will be doubled. So we have to be ready to really take on those aging patients that are having conditions that could impair their vision significantly. So here I'll walk you through some of the pieces of technology that actually give me that data that I can see before I see the patient and evaluate everything as if I'm all-knowing. So this is a piece of technology called the Visionix Eye Refract that I have been using now for 2 years. The main reason of picking this device initially was to move the refraction process, collecting the refractive data outside of the exam room, and give me more chair time with the patient to concentrate on consulting and educating and addressing the chief complaints. Now, this obviously gave me way more than just that. This data that is collected, as you can see here at the top, is giving me lensometry readings. It's giving me the wavefront readings. It's giving me the recommended manifest refraction. All of it comes with the PDs collected by the technology and the VAs through the lensometry final prescription and the wavefront readings, and also uncorrected VAs. All of that data is very important for me, especially with the patient coming in with their complaints that they are coming in with I can't see, and also the unperceived type of complaints that I can actually discuss with them. So, for example, I love stories, so I love to share that with actual clinical type exposure that I get in my practice. I had a patient recently who was a police officer, and he had LASIK not too long ago. Unfortunately, it wasn't fully correcting his nearsightedness. So when he came in, he already had a pair of glasses that was made for him elsewhere. And it gave him 20/20 vision, but his main complaint said, I cannot see at night. When I ran him through this technology, it indicated to me that the lower order aberrations for this patient with scotopic conditions, his vision was about a diopter difference for correcting his vision to 20/20. So I can screen that and see this and have conversations that I can bring up with a patient just from gathering this data in lighting conditions that are different than just doing traditional refraction. It also really captures a great wavefront readings for patients that have strong accommodation, my younger patients or latent hyperopes, and allows me to be a lot more accurate and a lot more successful than I previously have been with refraction in a traditional way with the Foraptor. That, as we all know, that piece of technology is many years old. So this new way of doing refraction not only is impressive to patients to see, but it yields these great results. Now, so great that my remake rate when integrating this technology for the last 2 years, company-wide, is less than 1% remake rate on the glasses. And so that leads to happy patients when they don't have to come back and tell me they can't see out of their new glasses. Here it shows you another piece of technology that that has allowed me to be able to practice remotely. The ability to see the anterior segment and to see more than just traditional way here with this digital slit lamp that has video capability, mybography integrated in it. It allows me to have conversations with the patient about Demodex, for example, and to be able to show it to them so they can take and engage into their own eye health and treatment options that I set up. The pictures really give you a lot of great tools to educate and enforce certain treatment plans to the patient that would be a lot more compliant than just talking about it. Same thing goes for dry eye treatment. Most of us spend many hours in front of screens. Blinking rate is decreased. Also, the aging population, naturally, those meibomian glands start to drop out. And before the patient has significant symptoms, you can see the count of these meibomian glands and what is happening to really give them a better treatment plan and to approach it in more preventative ways than when it's already happening and perhaps there's not much you can do. It also assists me in toric contact lens fits. I can see the conjunctival drag with the video capabilities, and I can see where the mark for the toric lenses settling. I can talk about different conjunctival injection and talk about changes with pigmentation that would enforce more of a coverage for UV protection. So there's a lot of conversation that I can bring up with the patient once they see these images themselves. This right here is a summary sheet of the VX650 that I'm able to have before, again, even seeing the patient. So there's a lot of data here that you can see on the summary sheet. On the top, there are wavefront readings in, again, photopic and scotopic conditions with the size of the pupil indicated for us on the left, and the patient's wavefront readings, which I have to say are quite accurate, and there's very little deviation I need to make in order to really combine the patient's habitual RX to the wavefront readings to finalize my prescriptions for best results. Next, we see the topography readings. How many times have patients asked you, well, what is the astigmatism? I know about it, but please explain it to me. So here on the topography readings, you can really easily explain them to me about the curvature changes and what that astigmatism really is for them. Also gives you great keratometry readings to fix any kind of complexities of more advanced contact lenses. And also the front section of the eye. Now, the anterior segment, we see a gross image of the front of the eye that can become a really baseline reading to track over time any pigmentation or changes that you may pick up on the patient, but also a cross section of the front of the eye. Here it gives me pachymetry readings to answer those questions. Well, doctor, am I a right candidate for LASIK? You already have that before they even think of asking that question. Also, the rule out any kind of narrow angle to avoid sudden loss of vision due to angle closure glaucoma. Of course, we have a beautiful wide view of the retina to really screen, make sure there's nothing to do with changes in vision due to their macular changes or anything to suspect like glaucoma on the optic nerve or more serious conditions like optic neuritis. Also gives you very reliable non-contact tonometry readings. This puff is very gentle, and most of my patients don't mind it at the end. On the bottom of the screen, you can also see here that I have it highlighted as a summary page, but I can dig in a little bit deeper to really understand the individual readings that are here for cornea, anterior segment, cataract analysis. It can even give you simulation of what the vision would look like with and without correction, especially for parents who are faced with the first pair of glasses for their child. They may not know how the child sees, and you can simulate that and show it to them. For the fundus images, I can break it up to grayscale to really understand any kind of issues that may be missed by looking in color, such as retinal hemorrhage. Here, it really, these normative data is collected, and it actually highlights problems if this data is not within the range of what everyone is as far as the data collected. And it really allows me to practice in a supercharged way. So having this data that is collected and compare over time is really the key to collecting it and explaining it to the patient why they need to come to me next year. Yes, I have normal data that they can see, but what if things are changing? We can pick up those changes so much sooner than if we didn't have them and a different doctor was looking at them next time. Here you can see one of those specific items on the cataract analysis. So here, without me being in front of the patient, I can actually see the cortical changes, the posterior cataract, the nuclear sclerosis grading. All of this can also be utilized in monitoring this cataract from an earlier stage every 6 months or so. If you're really a numbers person, you can really go deep into the higher order aberrations and how this vision affects. Even though you can refract the patient to 20/20, they may not see very clear, and that can really indicate to you why. And when you show this to the patient, it's much easier to really set up those treatment plans to educate them further on it. So here, anterior segment, it can rule out different conditions that may be missed if you did not have such a piece of technology to do your exam. As far as the corneal changes here is indicating the pellucid marginal degeneration. This patient just knows that they have a very high astigmatism and didn't really know maybe why, but this really facilitates in contact lens fitting for me, and being able to utilize topography, which can be broken down in axial and tangential version when fitting, for example, ortho case or scleral lenses. The patient really loves seeing these images, as you know, and it's, of course, a wow factor. But for me, it really allows me to not only detect, but also to practice in a way where it can give you options to expand your practice in areas that you really love. Let it be myopia control or dry eye treatment or whatever else it may be. Here you can see another patient that, and here I love stories, so I'm going to go ahead and tie it into a story. This is a patient that I saw, and he called. He's early 20s and contact lens wearer, and was a bit hesitant on scheduling an appointment if there was a wait. But because we were able to easily integrate him into our schedule that same day, he came in to use his insurance benefits to update his contact lens prescription. Now, he could have easily went on some sort of online platform and renewed his prescription that way. But because we made it so convenient and easy to access our office, he stepped in. So when we ran the screenings, here the normative data highlighted for me right away that there is a problem. So I had the technician run a few more readings here on the retina, and the patient did indicate he's a type 1 diabetic, and that after discussing with the patient afterwards, his sugar levels were a bit out of control. So here I can definitely easily see retinal hemorrhaging that is obviously causing the changes in his vision, which made it so easy and so fast for me to initiate that care coordination in order to really communicate with the PCP and the retina specialist and provide them these pieces of information to better assist the patient. Very unfortunate if the patient did go on some sort of online platform to just bump up his contact lens prescription a little bit, he could have went blind. These type of technology, it really allows us to see and detect serious conditions and help the patients, assist them in the best, most efficient and highest care that we can possibly get them. So the flexible access to quality care is the key here for me. And that was one of the things that really kind of resonated with me when I thought about building this business model. Increasing access to care is very important nowadays because there are more patients. Unfortunately, I think that some practices have long waiting lines in order to get them in, and today's patient wants options. They don't want to be on that waiting list. They want everything right away. So here is a kind of a busy chart, but I can go ahead and explain what I am trying to show here. So to simplify it, it demonstrates 3 ways I practice. On the top, you will see the asynchronous method. The right below it is the synchronous exam, and on the right hand side is me in person seeing a patient. So to kind of expand a little bit on each, the asynchronous is the definition of it is really you store and forward the information collected to the doctor. So the technician is able to have the patient come in and run the test, let it be a visual field, let it be a pressure reading, retinal images, cataract analysis, dry eye assessment, post-treatment, many number of things where the patient does not need to wait in line to see me. They can come in, run these tests, and then I can evaluate it later that day or the next day and get in touch with the patient to make the right assessment on how their treatment is going and if we need to adjust anything. So the second way of doing it is really the remote doctor experience that I provide for the patients. In other words, the synchronous telemedicine, where the patient and the doctor are separated by a distance, but interact in real time. And all of that is facilitated by video conferencing, which is a medical grade Zoom. Basically, the patient comes in. We already have their intake form in the EMR. The technician collects all of the data that you have seen me talk in this webinar just now. And as the patient is being transitioned to the exam room, the doctor already has their medical history and all the results in front of them, reviewing and kind of assessing it in their mind, how they're going to approach the chief complaint, the perceived and unperceived reason of coming in to see them, and what recommendations we need to make to this patient. The third version of me seeing patients in person, which is of course very important, this can be really set aside for patients that are the right patient for that. For example, if the patient already was seen in a remote manner and I picked up something that had abnormal results and we needed to bring the patient back for, let's say, dilation or anything in particular to address. ER visits, my preference, I always see these patients in person. More complex refractions like binocular vision refractions. And many other conditions that I could think of. But the ability to give the option to patient is really the key here. If the in-person visits were all of these, then we definitely would be backed up for weeks, months, and some practices, I'm sure they don't have any availability because the doctor is involved in every single version of these exams in person. This really gives a great option to patient without diminishing any care and being able to see the doctor on their terms, let it be evening, weekends, walk-in appointments. So really delegating this care and really making myself available for those more complex visits allows me to take care of as many patients as possible and give access to care to more of that modern day patient who wants everything in a very modern way with the highest technology to be able to combine the expertise of the doctor. And we have a team of doctors in our practice. There's 12 full-time doctors that are seeing patients and also remotely as well. So if, for example, there was a situation where there was a patient that came in for a remote visit and that day we needed to see that patient for dilation because we suspect a retinal detachment, because my practices are so close by, that continuity of care is to have that patient follow up within that day to a doctor that is nearby. This allows me to really practice in a way that is very responsible for the patient's care, where they have the remote capability to come in on demand, but also to be in person if needed. And also these doctors are someone that these patients already have seen year after year. And successfully provide the continuity of care for that patient remotely as well. So the key things to kind of recap here, really the message is that the demands of the patient are changing, and we have more patients. They need more medical care and early screenings with the aging population. The ability to take on that increased number of patients and really to provide the access of care to the patient. This model of optometry, where it really puts together the technology and the expertise of the doctor, to me is a win-win for the patient. The patient, feedback is that I can access whenever I need care, that high quality care. And for the doctor, the win is I'm more confident making these decisions because I have all this data in front of me that previously wasn't really utilized for screenings. It was more for in-depth evaluations like OCT for glaucoma suspects or whatnot. So the ability to integrate the expertise of the doctor and the technology, the doctor really practices at the top of their license with the full scope. So to kind of wrap it up here, my story, the benefits to patients, of course, are visible with the reviews that they provide for us, but it really gives them the fast, convenient results, easy access, no waiting list, the possibility of detecting pathology at a very early stage is there because of the technology that we use. And comparing this data year after year, I think it's always great to have baseline readings. Patients appreciate that. And it builds loyalty in high quality in this modern, in a modern way that the patient wants to accept their care from us.
All righty, and that was Dr. Rasa. So, and Dr. Rasa, are you still there?
I am still here, Adam.
Excellent. Yes. So as I mentioned to everyone before, you're in Mexico, so we wanted to take no chances, so we pre-recorded that. But thank you for making it out here tonight. So I guess we have a million questions here now coming in, and I'm going to try to work my way through them for you. So I guess we'll go from top to bottom, I guess, in terms of when they came in. So question here for you, first and foremost, you have 16 locations, and one question is here about scheduling. Physically, where are you when you're, on a daily basis? How do you actually work your practice? Did you stay in one location usually? Do you go to a bunch of different ones? How does it work?
So I am in a different location, but because we are building out these practices, and I usually locate myself in the newest practice, that is a cold start, and it's relatively slow. If you ever started a cold start, you know that you're not seeing that many patients per day, but each patient is very important because they're going to be your established patient next year. So I don't want to take any chances to not give access to any of them. So when I'm in that slower location, I'm able to take care of patients in other locations, usually maybe 2 or 3 locations if needed. And if another doctor calls in sick or there's vacation time and we didn't find somebody to fill in, the locations where we would have a doctor full-time, we still don't have to call the patients and cancel appointments. We can still take care of them. So I'm usually in one of my offices only about a mile or 3 away when seeing the patient remotely.
Right. And another question here sort of about the remote exams. When you schedule patients, do they know that they're going to be seeing you remotely? How does that actually work?
They do, yes. So most of our patients can schedule themselves online. I review my online scheduler, and each morning there's 100 new appointments that weren't there yesterday. So when we call to collect the information on the insurance, confirm their benefits, we triage to make sure that they're feeling healthy still to come in for the safe environment. We do let them know how the information will be gathered and how the patient will talk to the doctor. And we're very transparent, and some patients, chose still to be in person, and which is fine. But most patients are absolutely fine with this option, even though it is relatively new. So sometimes they're a little puzzled, but when they actually are okay with having the step exam, and at the end of it, they say that this was the most thorough, best exam they have received.
It's interesting. You actually started setting up these offices before the pandemic hit, and I wonder if patients before were a little bit more confused and befuddled, but now are more accepting of it just because it's what they've lived through for the past couple of years.
Absolutely, Adam. I think the entire healthcare system has integrated telehealth in some way or another. Optometry, I think, is kind of slower because our components are a little bit different. The patient does need to be in the office in order for a very full evaluation. They cannot be at home. And I know in some cases, optometry does have an option to take care of somebody calling in. But for me, I feel like having this technology and being able to collect all this data really gives me a really full understanding, comprehensive understanding on their overall eye and medical health when they are in office. So for me, it really just facilitated the patient's kind of acceptance that they are already aware that their primary care doctor wants to see them remotely, or psychology has used this for way before the pandemic. But every department in healthcare is utilizing it in some way. And the other thing that I would say made it really easy too is that patients are able to use Zoom. That is something that, maybe not everybody used it as much during the pandemic, but during that time, they talked on a personal level with their family members that they couldn't see, and they had to work remotely using Zoom. So when I Zoom into the office and I'm there on full screen in front of the patient talking to them, it's very natural for them. It's not anything new, and I believe the pandemic has really kind of helped with that as well.
Right. Question here just around costs. Do you have a sense of, maybe you could just sort of share like ballpark what it costs to actually set up a location with the technology?
There's a lot of moving parts when setting up an office. There is definitely a cost associated to it. The way I break it down in my mind is that I know what my lease payment is, and I can justify that by not turning away any patient. So if it allows me to see the patient, even though the doctor is not physically in the office, to me that justifies the return on investment immediately, because I can have 6 or 7 days of open doctor time. So I kind of break it down in that monthly payment of what the lease would be for me in my mind.
Right. And I guess with 16 locations, you've probably gotten pretty good about keeping the expenses in line, right? I guess the first one was probably a learning experience, and then each time you learned a little bit more.
My first practice was the most expensive practice. And then I learned all the different ways that I can negotiate with landlords, negotiate with vendors, negotiate with um, many different companies, let it be contact lenses or frames or whatnot. And there's so much to learn. And I'm sure that if you're part of certain groups, there's a consulting part that is available to you. And I think it's very valuable no matter which group you will pick to align yourself with. But doing your own research and learning from your own mistakes, I know for me, the first one was very big learning experience.
Right. Interesting question here. You mentioned you have 16 locations in around a 30-mile radius. Did you do any market research to decide where to put down those offices, or did just the right opportunity come along?
There's definitely demographics that you research, and you research how high density these neighborhoods are. For me also, because I work heavily with vision plans too, it's very important for me to understand where these patients are located. Where am I on the uh, kind of listing from on the providers? In in which kind of number on the list am I? So a lot of things go into deciding where that new location will be. But because we are a very neighborhood type of office, and there's a lot of great neighborhoods with a lot of identity in Chicagoland area, um, we are in a high traffic, foot traffic areas. So I always find a place that, would be patient would be able to walk up to the office.
Right. A question here, just I guess more nuts and bolts. What system do you use for the slit lamp remote?
So I use a slit lamp called Firefly. Um, and to me, it's has provided great optics, great video, and I'm able to screen share with the technician to really understand how the movement of contact lenses look and anterior chamber if I need to. Some technicians have obviously better training than others, but we work together very closely to really understand that anterior segment using that Firefly, and it gave me very good success so far.
Right. A question here, how often do you actually have to manually refine the refractions that the devices are spitting out? I mean, I know most people probably have some familiarity with autorefractors at some level. What's the experience like with your systems in terms of having to sort of modify what it gives you?
So the Visionics Eye Refract is definitely way more than an autorefractor. It has a wavefront technology to really give you a lot of information on that refractive status. So because the technology is such that I really don't have to modify it too much, because when I take into consideration and put my logic of what is the habitual Rx, what is the vision through it, what is that wavefront reading, what is that modified a portion that is recommended for the manifest refraction after the technician gives the patient a few subjective questions. So really it's right on. If I am ever in doubt, this technology, I'm able to tune into the office and control it remotely if I wanted to via TeamViewer, but I actually don't use that option much. So if I really needed to, I trial frame. So I have the technician pull my old trial frames and plug it in and have the patient take a few steps to make sure that that amount of cylinder power is not going to make them feel like they're in a little fishbowl. But it really kind of narrows down the ability, that very fine tuning between comfortable and clear vision. The technology is going to give you very, very clear vision, but the comfort is the one that I probably put a little bit of logic to really understand it. And in some case, I would trial frame. But again, the success is really good with that model that I put together for myself. Like I said, it's less than 1% remake rate.
Right. And I guess the other question that people ask is, obviously you're going to have staff running a lot of these machines. You're not doing it yourself physically, or in fact, not even there a lot of the time. What was the experience sort of getting the staff up and running? I know we usually have Melissa Renfro here, who's helped out a lot in getting offices set up, but I guess from the clinician side of things, what was it like for you to experience this and getting the new locations up and running? Did the staff have any particular difficulty?
No. These machines are very intuitive the way they are operated. It makes it very easy for somebody with very little refractive knowledge. And that was one of the reasons I chose this technology, because unfortunately, there is turnover in our labor force, and in general, labor force is not amazing nowadays for anyone, including me. So onboarding new help, they have to be able to at least right away be able to gather this data. And some technicians are faster than others at picking up certain skills, but I would say that some can do it within a few hours of using it, and some I never seen it more than a couple of days to really navigate through this. Of course, like any technology, and probably the one that I always refer to because everyone nowadays is very knowledgeable in, is EMR. So when you first get it, yes, you can navigate through the first day probably when you hook it up and set it up, but you keep learning about it as you use it more and more, different features. But just the initial onboarding and starting to use this technology right away to assist me is pretty minimum downtime.
Right. Oh, speaking of EHR, somebody wrote in with a question. Which one do you use in your practices?
So I use Eyefinity EPM and Eyefinity EHR. Um, but I believe that there are many, many platforms that can connect very easily with Visionics and OptoView equipment. I utilize both of them in my practice, OptoView and the Visionics, and it's easy integration. There's no issues, and other platforms like Revolution, like OfficeMate, like Crystal, I think they can all do that.
Yeah, I believe Melissa's told us that if you're using sort of a mainstream eye care platform, they've probably done the integration already, so it's not a big deal to actually set up an additional one. So,
Mm-hmm.
Oh, interesting question here. So, how do you deal with dry eye with patients who have a refraction that might be bouncing all over the place, especially when you're not there in front of the patient? How do you deal with that dry eye patient?
Yeah, so I mean, if I see that the results are a little bit fluctuating and something doesn't make sense to me, of course, we'll use the anterior segment information, and the Visionics equipment has the ability to do a non-contact tear breakup time that gives you a pretty nice grading of how far advanced is this dry eye. So I can see it remotely, and not just from gathering this data, but also from the chief complaint. As I start talking to the patient right away, my first questions are, well, you know, do you need to blink to clear your vision? Are you sometimes feeling something in your eyes, scratchy, gritty feeling, or whatnot it may be? And how many hours are you staring at the screen or the road for driving? So there's certain questions that I prep myself when I start to see some data that looks a little bit off. And initiating dry eye treatment is easier when you can show that on the screen. If anybody has dry eye clinics set up, and I can't say that I'm very advanced in setting up a one of those tear labs, but it's a very big portion of our patients that need our help with this, and being able to have my biography, and we utilize BluffX and Tear Care. You can set up these as follow-ups, as medical visits, or let it be really kind of self-pay type of visits for patients after you already uh, filter them through some remote exam or in-person exam that you see that they need more help. So it really kind of helps you generate other avenues, like dry eye treatment, or let it be myopia control or LASIK co-management, easier with this technology.
Right. And question here, what happens if you lose the internet? And I'm sure with 16 locations, it does happen from time to time.
So I've gotten smarter. I have backup internet, and I've never had an issue where I was just lost. And if it does come offline for a little bit, the technology itself does not need internet. You can still gather all the data. The problem is uploading into EMR for me to see it remotely. So, but I've never had it go down that long where I couldn't take care of anybody. And if we are, obviously when we first turn on the lights, and the first thing the technician does, their routine is to make sure that everything is properly functioning. And if something is not working, we would address it before we even expect the first patient to show up. But for something to happen where we just had to tell the patient, I'm sorry, you have to come back another time, I really have not had that. And maybe Chicagoland area has really good internet, but also we prep by having safeties, by having backup.
Right, and I will actually add, since I have this problem here, since we do run a lot of tech on ODwire, these days cell connections have gotten so fast with 5G that it's worthwhile to actually invest in a router that can automatically route to the cell network if it needs to, if your primary cable connection or DSL or whatever you're using goes down. It's become much more affordable, whereas years ago it was thousands of dollars to do it. Now it's very cheap, so it's something to think about. And let's see, I'm trying to see how many other more interesting questions that we have here. And interesting question here. Are you limited by vision plans or medical plans when you bill for an encounter that's not actually face-to-face?
I mean, there are certain regulations, and I would say not enough, because AOA has not really taken a big stance on this yet, and every state has their own kind of regulations on what can and cannot be done. So everyone should take a look at their state rules and understand that before they start something like this. For me, I dissected it inside out, and I'm doing everything that the state of Illinois permits. But the vision plans and medical plans themselves, some do have a little bit of kind of guidelines on that, but still, this is a pretty kind of green area where like there isn't a lot yet. So does it limit me? No, it does not.
Right, and so when you're actually setting up an appointment, you usually know what kind of exam it's going to be, correct? So you can actually sort of probe the patient's benefits before you
Yes.
even see the patient.
And when you code the exam, there's modifiers that you use to identify that this exam took place in a remote type of setting, synchronous setting, like I would be providing. So the provider, or not the provider, but the medical or the vision plan, they are aware of it.
Yep. And you, in terms of documentation, I know this was an issue, at least when the pandemic started, where there wasn't the need for, great documentation, right, using Zoom, because the tool obviously didn't have it built in. Have you seen any sort of a trend towards, more thoroughly documenting these telehealth visits?
The EMR that I have, I mean, once I document everything fully, kind of guides you. Yes, you collected all these pieces of information in order for it to be coded in such and such way. So I think that depends on what type of platform you use. But for me, Eyefinity really guides me in really not leaving anything behind. So it's a nice way to really know that I've collected everything and I noted everything in order for this visit to be coded in a proper way.
Great, and we're just about out of time. We had one more question here. If you could repeat the name of the slit lamp product that you used, I believe it was Firefly?
Yes, Firefly, and also the anterior segment on the Visionix 650 has a lot of information. So does the Visionix 120 Plus dry eye. They both are kind of like multi facet devices that give you a lot of anterior segment data, but the standalone slit lamp is the Firefly.
Great. All right. Well, Rasa, thank you so much for doing this today. We're going to be putting an archive of this talk up on ODwire, and I'm sure we're going to have a bunch more questions, and I hope you come on the site and maybe can answer a few more.
Great. Thank you so much. Have a great evening, everyone.
All right. Thanks, everyone.